At this time, I would like for all of you to welcome Dr. Myers.
Good morning. It truly is my honor to be here. God does talk this way, so if you need a translator, we can find one. This is my first trip to Columbus, but I do speak Southernese. I'm a native-born Southern guy. I want to talk about the end of an EMS system design that was designed for trauma. The EMS system was designed to move people to trauma centers after automobile accidents. And we have grown from there, and I want to talk about in the age of healthcare reform, maybe it's time to stop this you call, we haul, that's all thing. This is Obama's view of healthcare reform. Sorry, I'm trying to get the click. There we go. This is Karl Rove's view of healthcare reform, which is a bunch of taxes. This is the truth about healthcare reform today and tomorrow. It is very complicated. But off to both sides, the circles, one of those is the patient and one of those is the healthcare provider. And if we're not very careful, everything fills in the middle. And I'm afraid that that may be where we are today, and if we're not careful, where we are tomorrow. And you're asking yourself, well, what does this have to do with EMS? This is what it has to do with EMS. I'm going to have to back up, I think. This is what we do. Every day, we forge into the healthcare environment and we help people be calm. We bring order to chaos. So from my perspective, we are very well suited to step into this age of healthcare reform and not be followers, but be leaders. 5 to 10% of the population will call you every year. Name another physician group that sees 10% of the population every year. Very few. So we are there, and we do this every day, and I think we'll be good at it. So this is what I want to talk about. I want to talk about how we moved from trauma initially, which is cardiac arrest. And we'll review some stuff that's probably review for you, but just to hit the highlights. And then we'll move into areas where we do not have to transport people. And those include hypoglycemia, heroin overdose, and so forth. And then finally, at the end, we'll talk about what I think EMS is in the new healthcare environment, which is community health or community paramedicine or advanced practice paramedicine or however you want to phrase that, and where we're headed in that direction. So let's start then with cardiac arrest. We now know that this is the key. The 2010 AHA guidelines were the first AHA guidelines to change patient outcome. And for those of you that have been in the field and remember the days when you had to know the ejection fraction before you knew which antidysrhythmic to give, do you remember that? The old, roadmap to Boston flow chart for wide complex tachycardia. How many people did that save? 0, right? In fact, it may have killed a few, truth be known about it. So we now know that what we do in the field makes a difference here. And let's just review the data very quickly. Hardest time with that. The most powerful predictor of survival is what we do in the field. 32 times more likely to live from cardiac arrest if we get a pulse back as opposed to if you have ongoing CPR to the hospital. 32 times more likely. So this is us. This is not a hospital-based enterprise. This is an EMS-based enterprise. Resuscitation is ours. Post-resuscitation care is the hospital. And we know this because patients that do show up, even if they survive, have a less than 1% neurologically intact survival rate if there's ongoing CPR. So this is us. This is what we do in the field. These are those CPC scores graphically, and for those of you that are not familiar with that, 1 is normal, 2 is minimal deficit, quote, able to hold a part-time job. That's really what's in the definition. 3 is needs assistance with activities of daily living, 4 is persistent vegetative state, and 5 is brain death. You will note that there's no one in persistent vegetative state if they had pre-hospital ROSC. There's no red bar at number 4. So this is our deal, right? This is what we own. This is the end of you call, we haul, that's all. We should stay and fix this problem and then take them to the hospital once they have return of spontaneous circulation. For once, the AHA agrees with us. And I know we have a Mission Lifeline meeting this afternoon, and I'm surprised the AHA has let me speak at any of those because for the past 5 years, I really have been kind of anti-AHA until 2010. But in 2010, the guidelines came into kind of a congruence with the data about pre-hospital resuscitation. And even in their guidelines, they say you should conduct resuscitation where the arrest occurs. So this is not you call, we haul, that's all. This is what we should be doing. This should be the scariest slide for public health folks in the community. What we see here is the median survival from cardiac arrest is 8%. The median survival from BFET is 22%. That's not bad. The problem is the variability. If you look across the United States, in some communities it's as low as 13, in others it's as high as 16. In some communities it's as low as 7 or as high as 40. Do hearts really beat differently in Mississippi as opposed to in Minnesota? Probably not. There's no reason, there's no rational basis to have this disparate outcome across the United States. So why can that be? There's at least one plausible explanation, which is interrupted compressions, moving patients to the hospital rather than keeping them on the scene and resuscitating them. And if we look at that from a data perspective, I may have to stand up here. Sorry, I like to stand low, but the clicker's not moving from down there. So if we look at this from a data perspective, what we see is that if you stay on the chest longer, you will resuscitate people better. And if we correct that for all of the other variables, this is the take-home message. If you were on the chest more than 80% of the time, you triple the odds of survival. There's nothing in medicine that triples the odds of anything. But if you just stay on the chest, you triple the odds. And if you look at the variability that we saw initially, 8% all the way up to 40%, you put those communities here, a large portion of that variability is explained by interrupted versus uninterrupted compressions, moving patients versus staying and fixing them. So the mindset of EMS is that we should always run to the hospital, needs to start changing, particularly in the area of cardiac arrest, and we'll make the argument into some other things as well. Can we do quality compressions while moving? I'm not going to get into the mechanical CPR debate. I know better. I'm going to leave that alone. But in the absence of the mechanical CPR debate, this is a very interesting paper where they look at moving patients in cardiac arrest. And what we see is the numbers here. When you're on the scene with no feedback, there's no metronome, there's no little puck telling you, this is just plain old doing CPR. When you're on the scene, your correct rate is about 50% of the time. And when you're in transport, your correct rate is 10% of the time. A 30% drop-off in rate just by moving to the ambulance. The correct depth goes from 41% down to 8% by moving to the ambulance. This is not a good idea. Even if we provide feedback to you, it doesn't really change that much. If you go to the one where it gives you, push harder, push faster, the puck, we're not going to say which company that is, but if you give some feedback, you go to a 48% correct rate, but it still drops to 20% during transport. Your depth gets better on scene, 75%, but it drops to 14% during transport. So we know quality compressions triple your odds of survival. We know moving to the ambulance takes your correct depth and rate down by at least half. It's our business. Pretty straightforward. Okay. The last thing to say about this is it needs to be organized. And what is the difference? How many surgeons in the room? I know there's a couple. I just want to make sure I know where they are so I can know where my exit is to get out. What's the difference between a pilot and a surgeon? The pilot is invested. The surgeon goes home either way. Right? That's the old joke. What do pilots do every time before they take off? Run a checklist. They do not rely on their own memory. So the next thing that needs to change from our EMS perspective is we were always proud because we could calculate a dopamine drip on the side of the bed sheet. I don't want to put a dopamine drip in my arm that I calculated on the side of a bed sheet. Right? I wouldn't want that. But we were too proud to carry a checklist, too proud to carry a drug dosing list. So that's the next thing that changes as we move into the age of healthcare reform. We're going to be safer, and we're going to move to the age of the checklist. So positions are defined, and I stole this from Paul Henchy, who's the medical director in Austin, freely stole it. I love it because people copy this presentation and they can't think it came from us, so it's even better. But you define each role in the morning before the shift starts. That says, okay, if I've got a 3-person engine company, these are the roles, 1, 2, and 3. If I have a 4-person engine company, then there's a 4th position. And this operates regardless of what else is going on. It is paramedic proof, so that the basic life support continues regardless. This is what's called the triangle of life from their perspective. It's a checklist. And then on the inside of that, you can add your advanced life support. which is this diagram. So the paramedic comes in and interacts, but that triangle in the middle continues to operate. We don't leave, we stay and fix. So the notion of the checklist is very important. And these checklists are available, and you're welcome to download them or use them, but this allows us at 3 in the morning to make sure we are doing what needs to be done. Rather than reflexively running to the hospital, we can stand on that scene and really assist and change patient outcomes. These are just some examples of those checklists that I think are vitally important. So, the next phase of we're not hauling everybody to the hospital is obviously not everybody's going to be resuscitated. Even in the best systems, 50% VFVT, 16% of all other rhythms will get resuscitated. So we as healthcare professionals, as we move into the new age, have to think about what are we going to do for those that don't survive. Because unless things are different here in Columbus, there are no more community physicians in Raleigh. When your loved one dies, you don't call the primary care physician who comes out to the house and holds your loved one's hand. What happens is we are now the community physician for that person. And I'm sure you've experienced it here. Even the person in hospice, at the end of life, they call 911 just so that we can go hold their hand. And we need to be good at that too. And we need to embrace that side just as much as the resuscitation side. We need to resuscitate well, but even when we resuscitate well, half the time, they're not going to survive. So we need to be ready to handle that side as well. There are good termination rules, data-validated termination rules, so we don't have to have that question when we get back to the station, did we leave someone who might have survived if this or if that? We know these termination rules work, and we're just going to review them very briefly. The BLS rule is very simple. If it's not witnessed by EMS, there's never been a shockable rhythm, and you do not get ROSC on scene, those patients don't survive. And we'll look at the data about how well these rules work, but they work extraordinarily well. The other is called the ALS rule, and that's really a misnomer. It just happened to be this rule was validated in an ALS system, but as you see, there's nothing really ALS about it. Not witnessed by EMS, non-shockable rhythm, no ROSC, and no bystander CPR. And if those things are true, then what we see is that the BLS rule has a positive predictive value, meaning 99.8% certainty those patients are not survivable. Likewise, on the ALS rule, it's 100% positive predictive value. Nothing in medicine is that good. So we know it's okay to terminate these resuscitations in the home. Then the question comes, well, how are the families going to handle that? And you need a protocol. You got to have a deceased person's protocol to go with it. And then we have to be ready to deal with the families. And we don't do a very good job, at least in most places, with initial education about how you handle the grief process. We spend a lot of time on the resuscitation side. We don't spend enough time on how do you take the families through this part, and this is an important part of what we do. And this can also be data-driven. It can be evidence-based. There's only 2 questions we need to answer. Should the family be there, and how will they handle the news? And the answers to those are evidence-based, just as evidence-based as uninterrupted compressions are. The first of those is all evidence suggests the family should be present. 80% of all our pre-hospital cardiac arrests occur where? In the private home. What happens, whether the family member is physically standing in the room or not, they are listening to your resuscitation. They are going to be in the room next door, sticking their head around, seeing what's going on. And so what we have found, and I think what most have found, is bringing the family in reminds you that the family is still there. And it helps in a lot of ways. Number one, it keeps you from saying stuff that you don't mean to be pejorative, but we joke. It's part of the gallows humor that gets us through the stressful situation. But it can be misinterpreted by family members if they hear it in the other room. So having them physically present is very helpful. 80% of family members want to be present, but we only offer it about 11% of the time as an industry. So we need to bring those family members in for the resuscitation. This is a very important part of the grief process. 94% of family members who attended the resuscitation said that they would do it again and that it helped their loved one as they went through the dying process. They think it was good for the family member, so being present is a good thing. There's a 9-year study that says families don't interfere. We terminate about 320 resuscitations a year, give or take, in Wake County. in the Raleigh metro area, we have had 0 family member interference. It just doesn't happen, and they're always there. So we have found the same as this experience here. This notion that you might get sued, yeah, you might get sued. You might get sued for anything. But the notion that it's going to increase your chance of being sued by having the family member present is just not borne out by the literature. It's just not there. There is little concern with having family members present. There's been no lawsuits that are related to it. We think that we should have the family members in the room. We think that's true. The next part, though, is how do we take the family through the grieving process? And any healthcare provider, I think, needs to know these 3 things. Evidence-based grief process. These are the 3 things that families do better if we take them through. Number 1, that the knowledge from freedom from pain and anxiety for the dying patient. In other words, your loved one did not suffer, so long as that's true. Right? I mean, if they burned up in a house fire, please don't say that. You lose your credibility. But otherwise, going through and assuring family members that their loved one didn't suffer. Next is the cleanliness of the body. And finally is the physical touch of the deceased. If you think about a deceased person's protocol and these 3 elements, you have to involve your medical examiner so that they can allow you to clean the body, move them, and so forth. And we've worked with our medical examiner to be able to do that, and it's not all that complicated to do. There's only one study in the literature about EMS and families having non-transport. And I know there's emergency physicians in the room, there's emergency nurses in the room. This is a study that really supports paramedics terminating resuscitations. And the review of that is this. For all victims of cardiac arrest, 97% of the family members were satisfied with care. 100% of non-transported family members were satisfied, but a quarter, 25% of the patients who were transported wished they had been allowed to stay at home. So everybody's happy when they stay at home. 25% are dissatisfied when they go to the hospital. So we should end that. And here we go. I'm an emergency physician. Half of the families were dissatisfied with their interaction with the emergency physician. Why is that? The emergency physician was in a hurry. They didn't spend a lot of time with them, and they were dissatisfied. But within the margin of error, nurses and paramedics had a 100% family satisfaction rate. So the notion that families want to talk to a doctor at the end of life is us projecting onto the family. What the family really wants is somebody to explain what happened, a medical professional to explain what happened, and we in EMS are very well suited to do that. These are the things, needless to say, that they didn't like about going to the hospital. They rush to the hospital, they walk in the door, and their resuscitation is terminated within 2 minutes, and they're in a lonely waiting room rather than being at home around their loved ones. So staying at home is the right thing for this group of patients as well. So we should sit with them, we should be ready to resuscitate and resuscitate well, and then we should be ready to take them through the grief process. We've already talked about all of these things, so I'll move on. So that is the end of the first half, which is why you don't go to the hospital with cardiac arrest. That's the first interview call we haul, that's all. There's now the next phase of our maturity as a specialty takes us to other patients who can be treated and left on the scene. And we have 2 different groups for which we have excellent evidence. And I'm going to briefly review those 2. One is hypoglycemia, the other is narcotic overdose. There are a bevy of studies that look just like this one. And I'm not going to bore you going through all 37 of them. I'm just going to give you an example of one. And what you see is if you take patients and leave them at home after their insulin-induced hypoglycemia episode, then there's about a 1% chance that they will have a significant recurrence. 99% of the time they're going to do fine if it's insulin-induced. And this is just the example of that. P-values are there. The patients do well. Their repeat episodes are the same, whether they go to the hospital or not. You don't really fix them by taking them to the hospital. So there's about a 3% recurrence rate, but less than 1% have significant complications. So it's pretty safe as long as it's an insulin-based issue. In North Carolina, we are the Bible Belt and the diabetes belt. So we do this a gazillion times a day. Everybody in North Carolina has diabetes till proven otherwise. Heroin's making a comeback, in case you missed it. We had 3 hours in Raleigh 2 weekends ago where we resuscitated 6 respiratory arrests within 3 hours. We had a new batch of heroin. Apparently, it didn't pass the quality control measure or whatever. And so they got some folks in trouble. And I don't know if you've ever done this, but when you resuscitate them, they're often grumpy. And they don't want to go with you to the hospital. So here's the loop we get in, right? We wake them up with Narcan. They come up grumpy. They start fighting us. We put them down with ketamine and take them to the hospital, right? Does that make any sense to you? It doesn't make any sense to me. It seems like we're going in a circle. So there are 3 studies out of San Francisco, and then this study out of San Antonio. So you figure if it's true in San Francisco and true in San Antonio, it's probably true anywhere, right? I mean, that's the kind of the ends of the heroin extreme, I would think. They did a retrospective analysis of all their patients who were treated with Narcan. They would give them 2 milligrams IM while they were bagging them up. They would then establish an IV, give 2 more, and if they were completely normal at that point, then they would give them 2 more to go, IM, and leave them, rather than take them to the hospital. I love this outcome. Their outcome of interest was presentation to the medical examiner within 48 hours. So it was considered a success if you did not show up on the slab at the medical examiner's office within 48 hours. So they had 592 encounters, a lot of heroin in San Antonio. 40 were in cardiac arrest. Pushies were ongoing, so they were excluded. And of the remaining 552, none presented to the medical examiner within 48 hours. So they claim it's a safe protocol. This is my favorite slide of the presentation thus far, which is the reasons that the ones did present actually died. Heroin, cocaine and heroin, cirrhosis, hypertension, gunshot wound, fractured hip, gunshot wound, and heroin. So if you want to know what's going to kill people who need Narcan to wake them up, they're still going to come back about half the time and have a heroin overdose and die, but it's going to be multiple days later from that. The North Carolina legislature now has allowed us to leave the mister on scene with no liability. So we have added to our protocol, we're going to give you 2 of Narcan with a MAD device to leave with your loved one, like an EpiPen kind of thing, to kind of resuscitate you. All right. Finally, some things do not require a study, right? Take a minute. While people go. Yeah, it's the hookup with random chick that gets folks. But anyway, so Dr. Brenner was the director of CMS. He was a guy of integrity. He was very intelligent. He knew how to make things happen. So needless to say, they fired him in Washington. But he had a very interesting observation, which is healthcare is expensive when it's administered poorly. So we should not start healthcare reform looking at cost. We should start healthcare reform looking at quality care. And then the cost will take care of itself. So cardiac arrest, we don't haul because it's the right thing to do. I think we can leave hypoglycemia patients and narcotic overdose patients in a certain subset and not force them to go to the hospital. It's the right thing to do. And oh, by the way, that's cheaper, isn't it? If you think about it. They don't get the hospital bill, they don't get all the rest, but that's not the reason to do it. The reason to do it is the right thing to do, and then, oh, by the way, it's cheaper. Well, that's what they found here as well. So this is us historically, I think. We go to 911 calls, and we take people to the hospital, and occasionally we get good at hazmat and USAR and all that stuff, depending on how well you're trained. But I think this is where we want to be. We want to reduce the 911 calls. Repeat users are our frequent flyer programs. Diabetics, pediatric asthma, CHF, the homeless patients that call us a lot. We want to do better by them. And then some patients don't need to go to the ED. Maybe they can go somewhere else. And we can do this safely. And this, I think, is our greatest future opportunity. I think the evidence is there for what we've already talked about. Cardiac arrest, glucose, heroin. Now we go into the new age of healthcare and say, can we redirect, can we be the navigator of healthcare rather than you call, we haul, that's all. And there's some evidence to support this. So healthcare reform really is payment reform, right, as we know. We just need to put the ATM in the machine and we are ready to go. I grew up in a very interesting household. My mother is a very left-wing Democrat. My father is a far right-wing Republican. And so at one point, my mother came in and said, you have contributed more to the ACLU than anybody in North Carolina. And my father went, I've never given a penny to the ACLU. What are you talking about? She said, yeah, but I went through your checkbook, and every penny you gave to the Republican Party, I wrote a check to the ACLU for the same amount. So it was a balanced household. This is a problem in America, though. My father hates the federal government, but loves his Medicare. Well, now, hold on a minute. Because as time goes on, look what healthcare spending is going to do. It's going to be 1 out of every $5 spent. It is 1 out of every $5 spent. It's soon to be 1 out of every $4 spent in our country is going to be on healthcare. So we can mess with discretionary spending. We can mess with Social Security. You can do all that you want. But until you hit the healthcare curve, you haven't fixed a problem. So this is all of our problem. This is not somebody else's problem. It is ours. Heaven forbid the government may be forced to act like a business. I'm not sure that's a bad thing. So here's the challenges, right? We've got aging populations, and we know that 1/3 of the money spent is not spent on evidence-based care. This is not a death panel. This is not restrictions of care. This is not rationing of care. This is just don't do that stuff that doesn't work. And right now, we're part of the problem. Because what do? We haul everybody that calls us to an emergency department. The most expensive mode of transportation to one of the most expensive ways to administer health care for every problem encountered by 911. That just doesn't pass the whiff test, does it? For doing the right thing for the patient. So I think there's an opportunity here. We already talked about how many people will call. Between 11 and 52% of these transports are not necessary. And so we'll talk about the options here as we conclude. I think the battery is definitely close. Here we go. So if we look at what has increased EMS calls, it is not blunt trauma. It is not the fancy lights and siren stuff. It is generalized medical illness. It is nobody knows how to navigate our complicated healthcare system. So what do? They call 911. And I have, over and over, I say to our providers, we should not ask ourselves, why did they call 911? For the non-educated healthcare consumer, why would they not call 911? That's the easiest way to get health care, immediately. So I don't blame folks for calling. We've set up the system. We just need to do better. To speak the language of healthcare reform, these are the 3 things that healthcare reform is designed to do. And this is not a partisan issue. So I don't want to try to get into the politics of it. These just make sense. We should, number 1, improve the patient's experience. This includes, are they satisfied with the care? Are they happy with what we did? We should improve the health of the population. We should be concerned about the whole deal. And then, oh, by the way, we should look at cost. But that's the order. Make the patient happy, improve the population, and then, and only then, look at cost. So tomorrow's reality is this. Outcomes are going to matter. We're not going to get paid for process. We're going to get paid for how the patient did. The performance measures will be evidence-based. We're already starting to see some of that. For those of you that work on the hospital side, you know every time you see a chest pain patient, there's certain measures you have to meet and so forth and so on. That's coming to the EMS side. Care will be transparent, so the consumer will know what they're paying for. The cost of your service is going to matter, and we have already seen this in our community, and we're seeing it here today with the number of people that are here attending and who's sponsoring this. Hospitals have a renewed interest in EMS. They see the relationship that we can have going forward. And most healthcare is going to then start to focus on the out-of-hospital environment. The reimbursement mechanism is going to make them interested in what we have to do and what we have to say. We can do this, and we can do this today. Post-acute care. EMS is perfectly set and ready to do this. Long-term chronic care, post-ED care is within our capability. Certainly frequent system users, and I've already had conversations in the back of the room about how we can help these folks. This is not to say that they are abusing the system. This is their only access to care. How can we do better? The homebound patients and the healthcare screening are all within our scope of practice. So we've already talked about the triple aim, and I want to show you some examples of how this would work. So we today in EMS work right here. We work only at the event. It's time now to plug in to all of these people in our community that work before and after the event. This is one graphical way of looking at it. This is the easiest, in my mind, graphical way to think about where we're headed. Right now, you call, we haul, that's all. What we need is a mobile integrated practice where we are part of the overarching healthcare environment, and we can navigate patients where they need to go, to their doctor's office, to mental health, to add to their in-home care. Rather than being frustrated by these patients, we need to kind of run up and hug them, put our arm around it, and do the right thing for them. This is just a more detailed example of all the different things that can happen. And then here's 3 examples of ways that we can go forward. The first of those is vaccinations. Chicago had a great program. Basic firefighters on the engine went into the projects and gave vaccinations. Very well received by the community, very inexpensive, and increased their vaccination rate. Simple things that we can do. Diabetic care, we follow up and recheck our chronic diabetics glucose for them. We have people on the schedule every morning. We go out and say, what's your blood sugar today? And if it's above 300, do this, above 350, do that. Talk to their primary care physician, hopefully keep them from calling 911 with a blood sugar of 600 2 days from now. The readmission prevention is the buzzword, as you know. Patients with congestive heart failure, pneumonia, heart attacks that don't need to go back to the hospital, we are perfectly set to go see them in the first 12 hours after discharge. Walk in, see how you're doing, do a good community service for these folks rather than have them readmitted to the hospital. We have a couple examples from our community and then come into the conclusion. We have an advanced practice paramedic program. It's similar to some supervisors program. There's all different names for it. The bottom line is they're well-experienced medics, have had 1,500 patient encounters before they can even apply for the program, go through a separate academy, and then their job is to get out in the community and do what we're getting ready to talk about. We've focused a great deal on substance abuse, and we'll go into the details of that and falls prevention and how these programs actually work in real life. The first thing we have is a well-person check. This is the key to that. You go in and make sure that their vital signs are within the normal range and so forth and so on. If they pass that, then they're eligible for the things we're getting ready to talk about. Let's say you call because you're having a mental health or substance abuse crisis. I know that never happens here, but in Raleigh it happens all the time. And so the patient calls because they can't get access for their mental health complaint. They have no other complaint, but where do we go? An emergency department. I don't know about you, but if you are suicidal before you go into an emergency department, sitting in the emergency department for 10 hours is surely not going to cure you. But that's where we take folks. Now, does that make any sense? No, it makes no sense to take a suicidal person to the emergency department. So we go through this screening process, and this is what it looks like. We can't have given them ketamine or droperidol or whatever. They have to be calm enough to move, and then we will contact the alternative site for them. And these are the screening criteria. The only new skill that our advanced practice paramedics have is they have a breathalyzer so that they can go out and do the screening. We also incorporate our faith-based partners. So this is for the county mental health. We also have our faith-based detox centers. What is funny to me is the faith-based detox centers will take you up to 0.45 instead of 0.35. So the joke we always have is between 0.35 and 0.45, you leave the government and go to the Lord, right? They can't be tachycardic. They can't have an unexplained alteration in mental status. They've got to be able to take their meds. And this is the first partnership that's really been important to us. We contacted the Poison Center because this is what would happen, right? Somebody would they'd be anxious, and they'd have their mental health crisis, and they have prescribed Ativan, 0.5 milligrams 3 times a day. And they would be anxious, so they'd take a couple of extra. So they had 1.5 milligrams of Ativan. Well, the facility would say that's an overdose. We now call the Poison Center, and the Poison Center runs that through the algorithm, clears them to go, gives us a case number, and we can bypass the ED with those simple, I took a little extra Ativan cases, as opposed to the Tylenol cases that still need to go. So it's a nice screening criteria. Of course, we have to check everybody's glucose in North Carolina, as already stated. Over the past 12 months, 204 patients have been placed. They have been alternatively destinated, as we call that. These patients normally consumed 14 ED bed hours, so you can see now why the hospitals are interested. We have opened beds for about 816 chest pain patients over the past 12-month period. So this has saved $350,000 just in our direct billing costs. Forget what the ED charges would have been for these patients. Of the 204 encounters, only 4 subsequently went to the ED, and these are individual patient encounters. 3 of the 4 were the same patient who was gaming the system. I know there's nobody here that would do that, but there's a guy in Raleigh that thinks it's funny to, see how many different places he can end up in 24 hours. The ambulance gets in service very quickly. So the crews on the scene really like this. 10 minutes, I'm out of there. So it gives us unit hours back as well. This is the next program that we're kind of embracing the new healthcare reform, which is our Falls and Assisted Living Facilities program. What happens here is patients who fall in an assisted living facility, 80% of them are in a single physician practice in our community. Very aggressive group. doctors making house calls. They've got 75 physicians in their group, and they really target the assisted living population. So all of these patients are in their group, but you know what happens. They're found in the floor, and they call us. And the patient doesn't want to go to the hospital, assuming they have capacity. Their family doesn't want them to go to the hospital. You don't want to take them, and I don't want to see them when they get there. But because of the, I call it the risk creation department, it's probably the risk management department, but they move these patients away from corporate, right? They say that the assisted living facilities and corporate say you need to go to the hospital every time somebody's found on the floor. So we've worked with that private practice group. The IRB is in place, and we have now evaluated, I think it's on the next slide, yes. We began prospective evaluation of this in January of this year. We have enrolled 300 patients in this study, and we've encountered 30 of them. And 15 have been transported and 15 have been left on site, so we're early in the process. But there's a protocol where the advanced practice paramedic talks with the primary care physician, and if they meet certain screening criteria, they stay on site rather than going reflexively to the hospital. Now, to prove this protocol, I only need 950 more patient encounters, so maybe before I retire. There are actually 3,100 eligible patients in the community, so we're continuing the enrollment process. We're only about 10% enrolled. We hope to have a true answer for this in about 2.5 years. But the protocol is set to run that long. Finally, we are now in the process of rolling this part out. This is not in place today. We'll be in place by the end of the year. For those of you that work in the hospital, you know that there's a triage score, right? 1 for CPR in progress and 5 for stub toe and kind of everything in between. And we are now working to make sure our medics can establish that same triage criteria reliably. We're comparing that to the hospital outcome. And then we're going to offer alternative transport for those at the 4 and 5 level. We believe if you're going to the waiting room, you do not need to go to the hospital in an advanced life support ambulance or a basic life support ambulance for that matter. So that's where we are with that program. It's almost there. So in summary, I think mobile integrated healthcare practice is what we are about. It's what we've always been about. We've just been very narrow in our focus. We have said we are here for emergencies. And I realize that almost all EMS here is fire-based. But you and I know if you're a firefighter, you don't fight fire a lot of the time. And so what did the fire service do a long time ago? They embraced prevention. They embraced ways to keep the emergency from happening. And on the EMS side, I think we've been too focused on the emergency treatment side and not enough focused on prevention and alternatives for our patients. We treat emergencies well. We need to use our infrastructure to do some other things. So we end where we started. This is what we do. We are in a very scary time in healthcare. It's scary for us. It's scary for our patients. But we are uniquely suited because of the skill set that we have to navigate these patients through. We'll resuscitate those that are resuscitatable, hold the hand of families that need their hand held at that very moment of crisis, and then we talk about all the other patients we encounter, our diabetics, our heroin overdoses, and then we can move to this broad range of patients, falls in assisted living facilities, patients with mental health and substance abuse. You know the list in your own community, and we can integrate as part of that time. So my county manager always says, never waste a crisis. And we are at a crisis moment now in healthcare. And we have an opportunity from the EMS perspective to step into this crisis and offer solutions. And we can do it very cheaply, and we can do it because it's the right thing for our patients. And with that, I will stop, and I really appreciate the opportunity to be here, and thank you so very much.
That was a tremendous presentation. It makes so much sense. We have about 5 minutes, and then we'll take about a 15-minute break and reconvene at 10:20. Anyone who has questions for Dr. Myers, please raise your hand, and we'll have a microphone for you.
Thank you very much. So much. Thank you. Big room.
There has to be some questions.
Good morning. Thank you for your presentation.
Thank you.
Can you make this available via a Dropbox account or somewhere in the cloud so we can get a hold of it and take it back to our departments?
Yes, absolutely. As a matter of fact, I sent the Dropbox link to Mark, so just have him forward it. But it is Dropbox linked already.
Thank you.
Thank you.
A question over on the right.
I love what you are doing here. We had had a guy that's going to get his PhD that had left the fire department. One of the things he was looking at in his study is if we looked at possibly utilizing nurse practitioners to come out and examine these people, like as you were saying, get them connected to where they need to go, and just wondering what your thoughts are on that.
Sure. So it's interesting. We thought we were going to be real smart and create these healthcare plans for all of our frequent consumers of care. And so we got this list together, and we're going to, work with who's going to see him for this, who's going to see him for that, and have a really, comprehensive care plan. And we went to the Medicaid supervisor for the metro area just to ask a couple of questions. And they said, oh, you mean the healthcare plans we've already done? And plop them on the table. And 90% of the list were common. The patients that we thought needed healthcare plans and the list they already had created. So what I encourage folks to do is sit down around that table. Most Medicaid officers know more about this integrated model than anybody else in the community. And they have the nurse practitioner, they have the dietitian, they've got all that ready to plug in, and we have just been so focused on the emergency part, all you have to do is set out the table and reach out and touch them. But yes, it works very well to incorporate all of your allied healthcare providers in this, and it really has been easier than I ever thought it would be. All we had to do is go to the table and ask. But very good point.
Yes, sir.
Yeah, just jot it out.
Kenny, can you stand up for your question?
So, right, so the question is the stat about CPR moving to the truck, where was that obtained? That study looked at CPR in the residence and CPR in a non-moving ambulance. So it did not look at the CPR during that transport time where we all know it really goes downhill as you try to go out of the house. Offline we can have a mechanical CPR thing. Mechanical CPR is one of those things that is just not yet defined where its role is. There likely is a role for it, but it's hard to define it today. But that particular study was in the house and in a non-moving ambulance. Non-moving, right. So it gets worse when you when you go down the road. Absolutely.
Dr. Myers, back here. I'd like to thank you for coming to our community and sharing this very important information. Did have a question, though. Do you see any challenges in incorporating the practices you described for unscheduled care in a fire-based EMS system?
Right, so thank you for that. First of all, I want to say I'm speaking as an observer because in North Carolina there are 100 EMS systems. One of them is fire-based, and it's not mine. The other 99 are all third service. So having said that, the notion that fire departments cannot participate in this, I think, is very similar to the fire departments can't participate in fire prevention. In my mind, it goes in the same mindset of we are here to protect the community and we have to fight fires well. I look at EMS the same way. We are there to protect the community. We have to resuscitate cardiac arrest well, because if we don't do it, nobody does. Just like if you don't suppress fire, nobody does. But that's 1% of our calls, cardiac arrest. So the same is true in a fire-based system. The notion of reimbursement is where we are really trying to look now. Is how do we get paid for doing the right thing? That's the part of healthcare reform where there's a group of us working in DC trying to get that notion. And obviously, fire-based or third service, it's easy to follow the dollar, right? So I think we'll have some incentives that align to help fire departments do the right thing.
We have time for one more question. Yes, sir.
Yes, you're talking about departments that are actually reducing their manpower. How are they supposed to be able to do everything that you're talking about if they're in the process of reducing their manpower? Also, as a basic, what's going to be left with them?
Sure. So the two-part question. One is if you're in the midst of a reduction, how do you handle this as far as workforce reduction? And then secondly, basic versus advanced life support, and where does that work? I'll take them in reverse order. Many of these things are easily done by the basic level provider. One of the bigger things that we're doing is a falls prevention program in the homes of every patient that calls us over 65. We need to go back out to those homes and see if we can do falls prevention. There's a checklist for that. That's a very easy thing that has a huge impact on the community. So there's a lot of what we do here that is at the basic level or could be at the basic level, and that depends on your state scope of practice. For example, in our community, EMT basics can give albuterol. So if they go and visit the pediatric asthma patient, they can instruct and walk them through how to use albuterol as an example. So I think that's a scope of practice local thing. The broader question of if we're having manpower or workforce reduction, that makes this difficult. The only way that happens when you have reduction is going to be as it relates to reimbursement changing. I believe reimbursement is going to change. The notion that in healthcare reform, we're going to get paid only to take people to a hospital has got to change. And so once we are paid to care for people rather than move people, then it becomes in the interest of the organization to get at those dollars. So you reallocate the resources. But you're right, if there's a reduction going on, this falls by the wayside first. It would be the first casualty.
Again, that was tremendous. I'd like to thank Dr. Myers.
Thank y'all.
Thank you very much.
Thank you.